Okay, I guess hopefully everybody can hear me, and we're going to go ahead and get started here. And I guess as other people trickle in, I'll get them into the class. We are going to go over the muscles of the body again today. I sent you an email out for both lecture and for lab, listing the dates of the lecture exam and the lab exam. The lecture exam opened up today for chapters 3 and 24, the metabolism and cells, and it will be open until Friday night at 11:59. The lab exam opens up Friday morning and stays open until the 25th at 11:59. So they're back to back. You've got a week to get ready for each one of them. Should give you plenty of time to prepare. So anyway, it will not include the lab test 2 will not include muscles. Muscles will be its own separate test. So okay. Right now, the lecture test is just open for the Monday class right now. So the Tuesday class test will open tomorrow. So Tuesday, Thursday class, I'll open it up tomorrow. So okay. So let's go ahead and get started here. We're taking a look at muscles. Again, let's open up. I guess it would help if I would share the screen. There we go. Okay. So the list of muscles that we're addressing in the muscle test is found in the study guide for AP1 Lab. There's also a list, I think I've posted that in the content section in eLearn. And there's only 60 muscles altogether that we're looking at, not 206 muscles like bones like we're doing in the bone test with all the insertions and stuff like that. So it's a much easier, it's a much more manageable amount of material to review. So the first question we look at, though, when we talk about a muscle is how is it attached to a bone? And muscles are going to be attached to a bone in at least 2 places. It's going to have an origin. That's where the bone, where the muscle attaches to a bone that doesn't move. So it may be attached to the scapula, for example. So its origin is a bone that doesn't move. Its insertion is going to be a bone that moves. So, for example, you may have a muscle that attaches to the scapula. That's its origin. It originates from the scapula and inserts on the humerus. So the scapula doesn't move, but the humerus does. So the insertion is where it attaches to a movable bone. Now you can have more than one origin. You can have 2 origins, you can have 3 origins. Generally, though, you have one insertion, one movable bone. And so you pull on the bone, it's going to move. So you're going to always have 2 points, an origin and an insertion. And so we pull on the bone. We pull on the bone, and so the muscle has something to pull against. Because muscles contract, and they have to have something to attach to pull against. So that's what they do. So again, the bone that doesn't move is the origin. The bone that does move is the insertion. So here's this is an example here. This shows you the Sternocleidomastoid, and we talked about that in the week before spring break. Sternocleidomastoid consists of 2 large muscles that allow us to turn our head. Now, the origin of this muscle is on the sternum and on the clavicle. So it has two origins. Its insertion is on the mastoid process back here. So it has one insertion and two origins. Now the triceps brachii, the triceps muscle, has three origins. That's why we call it triceps, three heads, three origins. So anyway, insertion, the bone that moves, even though you may not think it when we turn our head, we're moving the mastoid process. So that counts as the movable bone. So taking a look here at our arm, we can see some of the muscles that we're paying attention to. These are the muscles that we pay attention to in the arm, in the forearm, for example. We have the brachial muscle, and in the upper arm we have the brachial muscle, which lies right between the biceps brachii and the triceps brachii. The biceps brachii is this muscle on the upper surface of our arm. It tucks up underneath the deltoid muscle. There's our deltoid, the muscle in our shoulder where we get, for example, we get injections that covers the end of our shoulder. On the posterior surface of the arm, we have the triceps brachii. Now the triceps brachii and the biceps brachii are antagonistic muscles. They work against each other. When the biceps contracts, the triceps relaxes. When the triceps contracts, the biceps has to relax because they are antagonistic. Now this muscle here is the brachioradialis. Brachioradialis starts on the humerus. It inserts itself down at the end of the radius. This is the muscle that allows you to rotate your arm when you're opening a door, turning a doorknob, turning a key, turning a screwdriver, any kind of action like that. So that is the brachioradialis. It allows you to take your hand and if you were to stick your arm straight out and then rotate it like you were turning a doorknob, for example. That's what the brachioradialis does. Here we see the brachioradialis on our skeleton. You can see its origin is on the humerus. Its insertion is on the very end, almost the styloid process of the radius. And when it contracts, it allows us to turn our arm. So now if we take a look at other muscles here in the arm, close up again. Again, there's the deltoid, covers the shoulder. It has an insertion on the humerus called the deltoid tuberosity. There's our biceps brachii. There's our triceps brachii. Now here's an unusual muscle called the teres major. You would think it belongs to the rotator cuff group, but it doesn't. It shares a name with one of the rotator cuff muscles, but that's all. It's not part of the rotator cuff, but it is a prominent muscle there at the shoulder, the teres major. If you have a major, you're going to have a minor. Just like when you have an anterior, you're going to have a posterior. If you have a superior, you're going to have an inferior, or like a supra or an infra, like you have on the front of the skull. There's the brachioradialis again, and there is our brachial or brachialis muscle. So the first one we see that we pay real close attention to on not just where it's located, where its origin and insertion are, but what it does is the biceps brachii. The biceps brachii is on the superior or the anterior surface of the arm. It has two origins, the scapula, both of which are on scapula, one in the coracoid process, the other in the glenoid. Scapula is good enough for the origin of the biceps brachii. It inserts on the radial tuberosity of the radius. Now, the radial tuberosity is that little bump on the radius just below the neck of the radius. And so it inserts itself here at the radial tuberosity, right there. There's the biceps. Its origins on the scapula. Its insertions on the radial tuberosity. When that contracts, when it pulls on the radial tuberosity, we flex our arm. Meaning we flex at the elbow. We bring our arm. If our arm is straight out with our hand flat, and we bring it back and touch our shoulder with our fingertips, that is flexing the arm. That's caused by the biceps brachii pulling on the radial tuberosity and allowing you to flex your arm at the elbow joint so that you can touch your shoulder with your fingertips. Since we can't go around all day with our fingertips sitting on our shoulder, we need to get our arm back into its regular position. And this is where the triceps brachii comes into play. The triceps is on the posterior surface of the arm, or the back of the upper arm. It has three origins, but it inserts itself on the olecranon process, the elbow, the olecranon process. And so if your arm is flexed, if you take your arm flat out and bring the fingertips back up to where they touch the shoulder, they're going to touch your shoulder, then since you can't go around with your arm flexed all day, let's extend our arm. So the triceps brachii pulls on the olecranon process and straightens your arm out. You flex and you extend, you flex and you extend. So the biceps inserts on the radial tuberosity. It allows the arm to flex. The triceps inserts on the olecranon process. It allows your arm to extend. I can't emphasize enough the need to remember both of those. Now this, let me get back one here. Extending the elbow joint. Biceps flexes, triceps extends, and here we see the action of the biceps and the triceps. If we're flexing our arm by bringing our arm upward towards the shoulder, you can see we're pulling on the radial tuberosity right there. If we're going to straighten our arm out, if we're going to extend our arm, the triceps pulls on the olecranon process on our elbow to cause our arm to extend. Triceps, extension, biceps, flexing. Deltoid muscle, the large muscle covering our shoulder, it inserts on the deltoid tuberosity of the humerus. Now, and there's our deltoid muscle there. There is the deltoid tuberosity underneath that muscle at that point. So, okay. And again, you can see there's the deltoid there. Now, this is one of the rotator cuff muscles. This is the supraspinatus. The supraspinatus is located in the supraspinous fossa, that flat area above the spine of the scapula. There's the infraspinatus in the infraspinous fossa. And directly below the infraspinatus is the teres minor. The teres minor is, you have a teres major, which is right there, but the teres major is not part of the rotator cuff, even though they share the same name. If you have a major, you're going to have a minor. If you have a minor, you're going to have a major. The teres minor and the infraspinatus and the supraspinatus are three of the four rotator cuff muscles. Now, the good news about the rotator cuff is that all four of them originate on the scapula. All four of them insert on the head of the humerus. So they all start the same place. They all end in the same place. So the supraspinatus in the supraspinous fossa, the infraspinatus on the infraspinous fossa, and the teres minor also in the infraspinous fossa. Of course, there's our deltoid there too. So the rotator cuff muscles, there are 4 of them. They come together at the head of the humerus, and they form a cuff that holds the humerus against the glenoid cavity. Now remember, the glenoid cavity is flat. It's not like the acetabulum. And so what happens is that there is no socket, if you will, for that to go into. But because the cuff is so tightly bound to the humerus is snugly held into the glenoid cavity. But the beauty of them is that because they allow movement in 4 different directions, is we have an extreme range of motion at our shoulder. You know, we can almost rotate our whole arm a full 360 degrees around the socket. So now the 4 muscles are the supraspinatus, the infraspinatus, the teres minor, and the one I didn't mention yet, the subscapularis. The subscapularis is in the subscapular fossa on the underside of the scapula. So, and this is the subscapularis right there. This is in the subscapular fossa on the underside of the scapula. Just for frame of reference, there's the biceps and the triceps. So, okay, now taking a closer look, we've taken the deltoid muscle off. One of these days, I'm going to turn this picture around. There's the deltoid muscle has been removed. We can see the spine of the scapula right here. Now, where this arrow is at the bottom, that is the supraspinatus, found in the supraspinous fossa. There's the infraspinatus. In the infraspinous fossa, there is the teres minor, also in the infraspinous fossa. That's 3 of the 4 rotator cuff muscles. With the 4th one, the subscapularis, in the subscapular fossa on the underside. Again, supraspinatus, infraspinatus, teres minor. Teres major, triceps, and none of these are part of the rotator cuff muscles. So, and here we can see the subscapularis on the underside of the scapula, right there. We can still, if we're looking at the subscapularis, we can see just the edges of the infraspinatus here. Because if we're looking at the scapula, looking at directly on it from, on our shoulder, sitting on top of the ribs, we'd see the infraspinatus, because there's our spine. I mean, there's the spine of the scapula right there. We'd see the supraspinatus, the infraspinatus, and the teres minor. If we were to be able to look through our ribs, we'd see the subscapularis and part of these other 2. But notice how the supraspinatus attaches to the head of the humerus, the infraspinatus and the teres minor attach to the head of the humerus, and so does the subscapularis. So all 4 of these muscles originate on the scapula, insert on the head of the humerus. And there's the 3 of the 4 right there. There's the supraspinatus, the infraspinatus, and the teres minor. You can see where they are originating on the scapula, inserting on the head of the humerus. Now, this is the motion that we see in this kind of action. We see here is the subscapularis. The only thing not showing here is the supraspinatus. There's the subscapularis pulling on the humerus. There's the infraspinatus pulling on the humerus. There's the teres minor pulling on the humerus. This allows us to have the flexibility to move in this extreme range of motion. Now, if you want to see what the supraspinatus does, let's add this in. And we see the action of the supraspinatus pulling the humerus elevating the humerus. Again, all three of these, all four of these muscles attach to the head of the humerus to give us this great range of motion. Here we see the motion of the supraspinatus, for example. You can pull in a variety of directions. Here we see the teres minor, allowing us to rotate our arm. Here's the infraspinatus, allowing us to rotate the arm out to the side. And the subscapularis, again, rotating the arm forward. So we have a tremendous range of motion here because these muscles don't operate, they don't operate individually, they operate together. And so you can have any kind of motion you want using all four of these muscles together. First, there's our infraspinatus and our teres minor working together now to pull our arm, to rotate the arm like this, rotate the humerus like this. Now, injuries to the rotator cuff, very common injuries to people. It depends on age. It depends on activity level. We tend to see two spikes if we're looking at ages of rotator cuff injuries. We see two spikes, one in early 20s and 30s, and one in 50, 60, and on up. Because contact sports cause a lot of injuries to rotator cuffs. A lot of repetitive action causes injuries to rotator cuff, a lot of blunt force trauma. Also, at the other end of the age scale, people wear out. People, get tired. People fall down and injure themselves. Normal wear and tear causes these muscles to become inflamed or causes the tendon to become inflamed or torn. Then they have to be surgically reattached back to, the tendon is what usually tears. What we're seeing here is a rotator cuff tear, and normally we can put in a plastic insert to reattach the muscle to the tendon, and it heals up gradually over 4 to 6 months, but the range of motion is as good as new, if you will. Very common in two age ranges, so it's not an unusual injury. There's your, there's the tendon on the supraspinatus right there, for example. Now, let's move into the leg, muscles of the leg. And we can look at this and we can say tibialis anterior, for example. Tibialis anterior is a muscle that is in the front of the tibia. Now, without even looking at the model, the name alone tells us anterior means in the front. Tibialis refers to the tibia. If you know where your tibia is located, then you would know that the tibialis anterior is in the front of the tibia. Well, we should know where our tibia is. This muscle is adjacent to that sharp edge, the anterior crest of the tibia, our shin bone that we find things with in our house at night when it's dark and we're walking around without lights on. That sharp edge of our tibia, the anterior crest of the tibia, the tibialis anterior is on the lateral side of that crest. Adjacent to it is the extensor digitorum longus, this long flat muscle here. Now we use the extensor digitorum longus to spread out our toes when we walk. We spread out our toes when we walk. Now what does the tibialis anterior do for us? Well, we use that to raise our toes, to bring our toes up when we take a step. When our heel goes down, our toes go up. So when we elevate the front of our foot, we put our heel down and we bring our toes up. When we put our foot down is when the extensor digitorum longus comes into play to spread out our toes. Now we don't notice it while we're wearing shoes, for example, but our toes are going to spread out to give us a better balance, a better standing, a better supportive position. So the tibialis anterior will raise our toes and lower our heel. We put our heel down, that's the tibialis anterior. The extensor digitorum longus, when we lower our foot, it spreads our toes out. There's a flat muscle underneath the calf muscle. It's called the soleus. It's directly underneath the gastrocnemius. This is the gastrocnemius right next to it, right in front of it. Right there, the gastrocnemius is what allows us to raise our heel. If the tibialis anterior allows us to put our heel down, the gastrocnemius pulling on the Achilles tendon allows us to raise our heel and bring our toes down. So the whole process of walking is heel down, toes up, toes down, heel up. We're walking heel to toe. And the gastrocnemius is pulling on the heel of the foot on the calcaneus bone to raise our heel so that our toes go down. And it does that by pulling on the Achilles tendon, which pulls on the calcaneus. The peroneus longus and the peroneus brevis are also involved with stabilizing our toes when we step. So these are all involved with motion and stability so that we can stand upright and not wobble. Now, taking a look at that was the lower leg. Let's take a look at the upper leg here. Big muscle on the upper leg, the gluteus maximus. Nobody ever gets this wrong on the muscle test. Gluteus maximus, referred to sometimes as the butt muscle or the cheek muscle or other less common names. Anyway, the gluteus maximus, large muscle there that we do not give injections into because of the presence of the big sciatic nerve running directly underneath it. So, but the gluteus maximus is a good landmark for us. Yeah, okay. On the other side of the gluteus maximus, now they're both on the lateral side of the leg. How do I know that? Because they're in the same side as the little toe. The tensor fasciae latae, large muscle there that runs all the way down from the iliac crest down to the knee joint. Now, so that is called the tensor fasciae latae. Now, the gluteus maximus, again, if you have a maximus, you generally have to have a minimus, and you may even have a medius, in between here. And if you want to find out where your gluteus medius is, you find your iliac crest. You can put your hands down by your pocket if you have a pocket, and you can feel, if you're standing upright, you can feel the edge, the top edge of the ilium. You can feel the iliac crest. And if you move back about 2 fingers width from the iliac crest, you are on a location of the gluteus medius. And the gluteus medius is an excellent place for injections into the hip. But the gluteus maximus is not, because the location of the sciatic nerve runs right through there underneath the muscle, and the gluteus and the sciatic nerve at that point, it's about the size of your finger, large, thick nerve. The odds of hitting it are very good, and you don't want to do that. Okay. Now, another perspective on the extensor digitorum longus. This is someone that causes the toes to spread out. You can see how it connects to all 5 phalanges that make up the toes. There's the peroneus longus, the peroneus brevis. Here is the tibialis anterior again, directly adjacent on the lateral side of the anterior crest of the tibia. And of course, there's the soleus underneath the gastrocnemius, which didn't show up in this one. Okay, now There's the gluteus maximus. There's the iliac crest right there. The gluteus medius is located in this area here. You tend to avoid trying to give an injection right in here. So, okay. There's our tibialis anterior. On the anterior side of the tibia, it is on the lateral side of the anterior crest. It causes you to raise your toes. Heel down, toes up. Plantar flexion, the opposite, which is what the gastrocnemius does, causes you to elevate your heel and your toes go down. So this toe down and toe up process is the whole thing, part of walking. So there is the tibialis anterior right there. When it contracts, the toes go up and the heel goes down. When the gastrocnemius contracts, the heel goes up and the toes go down, just the opposite. So we call it dorsiflexion of the foot, bringing up the toes. Okay, let's move to the upper leg. These are the quadricep muscles. There are 4 of them. The quadriceps, or quads, consist of 3 muscles that have the same first name: the vastus medialis, the vastus intermediate, and the vastus lateralis. Now, you can see the vastus intermedius. It's underneath this ringer here. This is the rectus femoris, but the vastus intermedius is directly underneath that. Right there. There is the vastus medialis, vastus lateralis, vastus intermedius, and the rectus femoris. These are the quads. Now, the medialis is on the medial side of the leg. It's on the big toe side. The big toe is always on the medial side. The little toe, the lateralis side, is also the lateral side. So the vastus lateralis lines up with the little toe. On our legs, we can't turn our foot over like we can our hands. We can't say that the thumb is always on the medial side when we flip our hand over. Now it's on the lateral side with our foot. The big toe is always on the medial side of the leg, and the little toe is always on the lateral side. So whatever side the big toe is on is the medial side. So the vastus medialis is lined up on the same side as the great toe. And the vastus lateralis is lined up on the same side as the little toe. Vastus intermedius is in the middle. And for whatever reason, we have the rectus femoris as the name of the 4th muscle. So what does this muscle do? Well, the rectus femoris allows us to flex our thigh or extend our lower leg. We flex the thigh, we flex our thigh, or we extend our lower leg. Now, the antagonist to the rectus femoris, and the antagonist to all the quads, is the hamstrings. These 3 muscles on the posterior side of the leg, we have the biceps femoris, the semitendinosus, and the semimembranosus. Now, how do you tell them apart? Well, it's difficult because on the model, the semitendinosus and the semimembranosus are fused together on the model. So, however, the semimembranosus is on the medial side. And how do I remember that? Because of the M in membranosus. I know it's but it works. Semimembranosus on the medial side. The semitendinosus is on top of the semimembranosus. So T for top, M for medial. It's lame, but it works. At least it works for me. That means the other one has to be the biceps femoris. So if the two semis are on the medial side, then the biceps femoris has to be on the lateral side. These are the hamstrings. There's only 3 of them. Here's what the model looks like. Here we see the biceps femoris. That means this is the lateral side we're looking at here. That means that the little toe is down here somewhere, and the great toe is over on this side. Because now we're looking at the semitendinosus on top of the semimembranosus, which is just visible, slightly visible underneath the semitendinosus, right there. Membranosus, medial side, tendinosus on top. So these are the three hamstrings. So, and what does it do? It extends the thigh and flexes the lower leg. Sounds familiar. Let's go back here and take a look at the quads. Remember, this says extend the thigh and flex the lower leg. Well, the quads don't extend the thigh, they flex the thigh and extend the lower leg, just the opposite of what the hamstrings do. So the quads flex the thigh and extend the lower leg. Let's go back here. So the hamstrings do just the opposite. Instead of flexing the thigh, they extend the thigh. Instead of extending the lower leg, they flex the lower leg. So this is the opposite action. Now you can take a look at this. If the hamstrings are relaxed, the quads are contracted. The hamstrings are relaxed, the quads are contracted. If the quads are contracted, then the hamstrings are relaxed. So consider what we're doing right now. We've just extended the lower leg. We just extended the lower leg. Now we contract the lower leg. We extended the lower leg. Now we flex the lower leg. The hamstrings allow us to flex the leg. The quads allow us to extend the lower leg. What did we say back here? Extend the thigh, flex the lower leg. And that's exactly what we're doing here. When our hamstrings contract, we flex the lower leg. When our quads contract, we extend the lower leg. So that's the opposite action. Every time when you bend your leg at the knee, you bring your leg back up underneath you. You are flexing your leg, and the quads are doing that. When you extend the leg, the hamstrings are doing that. So those are the antagonistic actions. Those are the antagonistic actions of the quads and the hamstrings. And like I've said, most of our muscle groups are going to work in antagonistic ways against each other. So let's take a look here. Some other muscles to pay attention to. Now on the inside of the thigh, on the medial side of the thigh, we have a series of muscles that allow us to do some, give us some great flexibility. This first one that you see here is called the sartorius. It's like a strap. The sartorius allows us to flex our thigh to the point that we can sit cross-legged on the floor. It's a very unusual muscle. It looks very much like a strap. And it comes down across the inside of the thigh like that, almost to the knee. But this gives us this ability to sit cross-legged. Adjacent to it is a muscle that runs from the inguinal region up near the groin all the way down to the inside of the knee. It's called the gracilis. This is going to stabilize our thigh and allow us to rotate. Underneath the sartorius is a muscle called the adductor longus. And if you have an adductor longus, if you have a longus, you may have a brevis, you may have, other names like that, but generally if you have one name like longus, you should have a brevis, but here what we get is adductor magnus. So not every naming convention plays by the rules. But the adductor longus runs underneath the sartorius. The adductor magnus starts here at the very end, at the end of the ilium, and runs underneath the gracilis and underneath the sartorius. What do these muscles do? They're all there to help stabilize the thigh. There's the gracilis on the medial side of the thigh. It allows us to flex our thigh and stabilize our thigh. The sartorius allows us to sit cross-legged on the floor. And the adductor longus allows us to move our thigh towards the midline. The adductor longus and the adductor magnus work together on that. So, okay, now we get to the lower leg. This is one of the really important muscles here. This is the counterpart to the tibialis anterior. This is the gastrocnemius muscle. The gastrocnemius muscle has a lateral head and a medial head. It inserts, its origins are on the lateral and medial condyles of the femur. It inserts on the calcaneus bone of the foot by way of the Achilles tendon. There's the lateral head, there's the medial head. There is the Achilles tendon inserting on the calcaneus bone right there. The gastrocnemius, calf muscle, it will cause us to raise our heel when we walk. Plantar flexion, we put our toes down and our heel comes up. Our toes go down, our heel comes up. And then we put our heel down, and then our toes go down, our heel comes up, our heel goes down, and we walk heel to toe. This allows us to walk. And so we have, it is the counterpart, it is the antagonist to the tibialis anterior. Now, the origins of the gastrocnemius are on the medial condyle of the femur and the lateral condyle of the femur. The lateral head originates on the lateral condyle. The medial head originates on the medial condyle and inserts on the Achilles tendon. Again, there's our gastrocnemius muscle. There's our medial head. There's our lateral head. There's our soleus. There's the Achilles tendon right there. And this is what the gastrocnemius does. The tibialis anterior causes dorsiflexion, causes the toes to come up. The gastrocnemius causes our toes to go down by elevating the heel. We raise our heel when we take a step and the toes go down. We dorsiflex when our heel goes down and our toes go up. And this is how we walk. So, plantar flexion is what the gastrocnemius does for us. And again, what is the difference between dorsiflexion and plantar flexion? Dorsiflexion, the heels, the toes come up thanks to the action of the tibialis anterior. Plantar flexion, the toes go down, the heel comes up thanks to the action of the gastrocnemius. Now, taking a look at the torso, we see another one of those muscles that nobody ever gets wrong. we have the frontalis muscle, very thin muscle. Because you can feel your frontal bone through your skin. So there isn't much muscle there. The muscle is used mostly for expression. It's mostly for expression, and it doesn't really do a whole lot for us there, but it is quite prominent. There is another expressive muscle, shows emotions and feelings, the orbicularis oculi. It's nothing to do with the motion of the eyeball. It has everything to do with showing expression. Same, the orbicularis oris. You know, oculi refers to oculus, that's the orbicularis oculi. The orbicularis oris, the oral opening, so that's how you keep those straight. Again, nothing to do with chewing or eating or speaking. It has everything to do with showing emotion. And there is the sternocleidomastoid, one of the more prominent, the most, what could be, is arguably the most important muscle there around the neck, but we'll let that one go as an argument. Anyway, zygomaticus muscles, again, emotional. They don't allow us to show emotions. They don't do a whole lot with movement or chewing or anything like that. So close up on the head. There's the frontalis right there. There's the orbicularis oculi. There's the orbicularis oris. And these are the zygomaticus muscles here. And you can just see part of the sternocleidomastoid right here underneath that. So there's the frontalis muscle. It has two parts to it. It's not like the frontal bone, where the frontal bone get fused together into one large bone. Our frontalis muscles formed from membranes the bones formed from membranes. The frontalis muscles formed into two distinct parts here. So now the let's see. Okay, orbicularis oris, orbicularis oculi. Again, just a circular ring of muscle that again, for showing expression. It's part of our expressive nature. Now, here we see this is one of the chewing muscles. This is the masseter muscle. The masseter muscle is attached to the zygomatic bone and to the mandible. And when the masseter contracts, the mandible is brought up against the maxilla. The only way that we chew is to have the mandible brought against the maxilla, because the maxilla doesn't move, only the mandible moves. And that little muscle right in front of this big salivary gland is what pulls the mandible upward. There's our zygomaticus muscles, again for expression. There's our sternocleidomastoid. Its origin is down here on the sternum and on the clavicle. Its insertion is on the mastoid back here. This allows us to turn our head to the left or to the right. If the left side contracts, our head will turn to the left. If the right side contracts, our head will turn to the right. As they both contract, our head will nod up and down. So this is the sternocleidomastoid. Large, powerful muscle. It attaches to the mastoid process on each side. Rotation of the head. Whichever side contracts will cause our head to rotate in that direction. If they both contract, then our heads will nod up and down. And then sometimes you get extreme raises like this, which you really don't want to see. So anyway, Now this muscle is the other chewing muscle we look at. This is the temporalis muscle, and its origin is on the temporal bone. So temporalis now on the temporal. This muscle actually does something because its origin is on the temporal bone. Its insertion is on the mandible also. And it also pulls the mandible up against the maxilla. So that allows us to be able to chew. There's the masseter again. So these are the two big chewing muscles that we're involved with. Here we see the temporalis and the masseter. The masseter's origins on the zygomatic bone. Its insertion is on the mandible. The temporalis's origin is on the temporal bone, and it inserts on the mandible too. And now what it does, the masseter elevates the jaw, the mandible, to bring it up against the maxilla to chew, and the temporalis does essentially the same thing. And so we get this chewing action of pulling the mandible up against the maxilla, which looks something like this. Notice that the maxilla doesn't move, only the mandible is moving. You can see the tongue here, but only the mandible is being brought up against the maxilla. That's all. Okay. Now let's move down below the head and into the torso. Here we have the trapezius, a triangular shaped muscle that's above the deltoid. There's the deltoid. Here's the trapezius up there. Here is the pectoralis major. And if you have a pectoralis major, you're going to have a pectoralis minor, and we do. And it's directly underneath the major. Usually it'll run in the direction of the tissue. Will run in the opposite direction. You may be able to see just the edge of it here. And then there is our diaphragm right there. Now, pectoralis major sits on top of the ribs, allows us to climb up ladders, climb up ropes, to throw things, to throw baseballs, to throw rocks, to throw anything. You get out of the axe house, you can throw axes. You use your pectoralis major for that. If you do push-ups, you can you'll be using the pectoralis major. There's the pectoralis major right there. Now, on the back, we have the trapezius. The trapezius is a large triangular shaped muscle that allows us to move our head and to move our shoulders, actually to move our scapula. It can allow us to raise our head up. It will allow us to elevate the scapula. And we'll see here, the trapezius allows us to elevate the shoulders. It allows us to turn our head, tilt our head side to side, not turning our head like the Sternocleidomastoid does. This is laying our head over to the side. It allows us to tilt our head backwards or forwards. It allows us to elevate the scapula like we are shrugging our shoulders. When we raise our head up to look at something and be a little more prominent when we look at it. Now, the latissimus dorsi is directly below the trapezius on the lower back. And this is a very powerful muscle that we use frequently when we are chopping wood, when we are sawing wood, when we are driving a nail, when we are throwing a ball underhand in particular, like in softball, for example. This is a very powerful muscle. You have a lot of energy going into your power stroke down, like when you're driving a nail. and it extends all the way down to the sacrum, and it inserts on the humerus. And so it puts a lot of power into the actions of the humerus. This is the latissimus dorsi right along in here. This large, powerful muscle is the latissimus dorsi. And what it's doing, there we go. Throwing something underhand, for example. Bowling, if people bowl. Throwing anything underneath, depending on the power you put behind it. You'll notice how this muscle is attached to the arm right here at the top, near the top of the humerus. So this large, powerful muscle can put a lot of power behind on this kind of action. It also is used when you bring the arm over the chopping wood, driving a nail, something like that. So anyway, latissimus dorsi. Along the side of our torso, we have the serratus anterior. This is often referred to as a boxer's muscle, because this places a great deal of energy into the arm. It's often used, if a person is engaged in boxing or mixed martial arts or something like that. Those kind of actions, the power behind the hand and the arm and the fist are directed by the serratus anterior. There's the pectoralis major. And this little section right here is probably the pectoralis minor, you see. So, now, the rectus abdominis, the six-pack muscles across the front of our abdomen. It starts on the pubic bone, it inserts on the xiphoid process. This is the one that we flex. We're unaware we flex it when we want to stabilize. When we want to stabilize our torso, you got to pick up something very heavy, and you find that you're holding your breath when you do that. The reason that happens is because you have contracted your rectus abdominis. You do that to stabilize your torso, and you find that when that happens, you're holding your breath, you're getting a shorter breath. When you're straining, when you are picking up something very heavy, and it really hurts to lift this up, and you're creating a lot of internal pressure in the abdominal cavity. That's because you have compressed the rectus abdominis. An individual who is constipated, getting into healthcare for a person who is constipated will probably strain to empty their bowels. And because when a person is constipated, the water content is less than normal, and so the fecal matter doesn't want to come out, so the person strains. And they're raising their pressure to do that and try and push that fecal matter out of the bowels, out of the large intestine. Raising that pressure can be very detrimental in a cardiac patient. Cardiac patients are often given pain medication because they've had a heart attack or something. Pain medication often inhibits the action of the large intestine. In other words, pain medication often makes them constipated. Well, if they feel the need to empty their bowels, your cardiac patient may often strain so hard to empty their bowels that they will stimulate there's a nerve that innervates their heart called the vagus nerve that runs through the abdominal cavity. If that nerve is stimulated, it slows down the heart rate. And many cardiac patients have strained themselves into another heart attack or death by raising the pressure in the abdominal cavity. If you've ever picked up something heavy and felt a little dizzy after you picked it up. It's because you were slowing down your heart rate and you were holding your breath. It's not unusual. You know, whenever we strain, this is what happens. Anyway, this is the rectus abdominis. So, the external obliques are on either side of the rectus abdominis. We use these to compress the abdomen. Again, we use these for, you know, stabilizing the abdomen so we can pick things up. Here we see again the serratus anterior. Here we see the external intercostal muscles. These are the muscles that are between the ribs. They contract and our ribs rise. We have external and internal muscles. The external muscles, the grain on the muscle runs towards the sternum. The internals run opposite direction. Here we see the rectus abdominis again, and there are the external obliques again. Now, the internal obliques are located underneath them. If you were to stand up, put your hands in your pocket and point the fingers towards your midline, you would be in the location of the external obliques. Now, the internal obliques are directed underneath, only they're going in the opposite direction. All we can see the internal obliques here is this little line. There's the internal intercostals. They run away from the sternum, whereas the externals run towards the sternum. There's the transverse abdominis, and now this large muscle that runs across the edge here is the diaphragm. It's not this area down here. It's just shows up as the edge of this muscle. There's your external intercostals running towards the sternum. There's the sternum right there. And there's the internal intercostals running away from the sternum. The external intercostals elevate the ribs when they contract. The ribs rise. When the internals contract, the ribs depress. And so air goes out. Now, our diaphragm, shaped like a parachute, comes up underneath the sternum. The top of the diaphragm is located about where the xiphoid process is located. You can see how the diaphragm covers this whole area in here. And when it contracts, this moves down and the thoracic cavity gets larger. When it relaxes, it rises up like this. So what we're seeing here is a relaxed diaphragm. It would only drop down when it contracts. And you can see here, as it goes down, it's when it's contracted. And when it goes down, the ribs are going to rise up at the same time. You'll see here in a second when the ribs show up. There's the diaphragm. There are the ribs. When the ribs elevate, the diaphragm goes down. And so we increase the size of the chest cavity to suck in more air. And that is everything I want to show you on the muscles. Questions on anything? Okay. The muscle test is several weeks away, so I wouldn't worry about it. Your focus this week should be on your lecture test, and then next week on the bone test. We will have the muscle test probably, I don't know, we've got plenty of time, so I would think that probably by the first week of April, I'll figure out a time. So, but don't worry about the muscle test just yet. You need to focus on the bones and the bone test and the lecture test. So, any questions on anything? Okay, then I'm going to get us out of here. If you have any questions on anything, shoot me an email. I'll be glad to get back to you. So, otherwise, we're done.